This program is brought to you by Emory University.
Good morning, everyone. We'll go ahead and get started. Welcome to Heart and Vascular Grand Rounds. I want to introduce Dr. William Nicholson as the Director of Interventional Cardiology at Emory Heart and Vascular. We'll be talking about contemporary complex percutaneous coronary revascularization.
Yeah,
Turn it over to
thanks, Pratik. Yeah, so I'm going to be brief. I'm going to let Mariem and Maddie take most of the time here, but it's just a chance for us to kind of update what we've been doing in interventional cardiology and the complexity of the cases that we're taking on and some of the new data and some of the new devices and techniques that we have coming available. There's really nothing that isn't intervenable at this point in time. There's between the combination of mechanical support during the cases and the complexity of the techniques that we're able to employ, there's really no anatomy that's not approachable. And so when there's surgical turndowns or people are not good surgical candidates, there's really nothing we can't approach. So I'm going to let Maddie and Mariem take over. Maddie Barker's been with us for 2 years now. She's one of our CHIP fellows, which is a complex high-risk interventional program. She's going to be going to up north for her next endeavor for her career. And then Mariem Sawan, and Mariem's been here for quite a while now. I don't know how many years you've been at Emory, Mariem, but we've been lucky enough to have her for cardiology and then interventional. Now she's one of our CHIP fellows, and both just super hard workers and excellent in the lab and going to be great in the field. So I'm going to let, I don't know who wants to start. Mariem? Okay, I'll let you start.
So we have no disclosures, and here are our objectives. We're going to touch upon the contemporary CTO PCI for the management of graft failure post-CABG, complex PCI for left main and multivessel artery disease, emerging treatment options for in-stent restenosis, and emerging treatment options for refractory angina.
Hard on more total closures and try to learn how to deal.
A quick video on Andreas Grunzing describing how important it is that we be able to approach and intervene on chronic total occlusions.
Total closures. We did a study on that, and we found out that 70% of the patients who are rejected for dilatation had been patients with total closures in one or the other artery, while having more disease in the others. Therefore, the total closure is a real problem. We cannot solve the total closure problem. We probably will never really address the question of multivessel disease dilatation.
So we're going to start off with a case, and this patient is a 65-year-old female who presented with chest pain and admitted with NSTEMI. Her troponin peaked at 540. She has a past medical history of CAD with a PCI of her LAD 10 years ago, type 2 diabetes, hypertension, and peripheral artery disease. She's on optimal medical therapy. And here are her initial angiograms. There's severe ISR of the prox to mid LAD with an IFR that was measured at 0.83. There's mild disease of her circumflex. And then her RCA is a CTO with an ambiguous cap. Her LV function is normal. So we discussed her case at the heart team meeting. She has a Syntax score of 31, and we decided to enroll her in the RECHARGE trial, which is an ongoing trial. It's a prospective randomized trial comparing CABG versus PCI in minorities and in women. We brought her back for the LAD, a staged LAD PCI. Intravascular ultrasound was evident for new atherosclerosis as a mechanism behind her ISR. We performed atherectomy with a cutting balloon, dilated with a non-compliant balloon with good expansion, deployed the stent, and optimized with a non-compliant balloon, and made sure that we IVEST, which is intravascular ultrasound, to make sure that we have excellent stent expansion and no edge dissections. We brought her back for a staged CTO PCI, and because of the ambiguity of the proximal cap and the length of the lesion, we opted to use an approach called antegrade dissection re-entry, which is basically we intentionally dissect and enter into the true lumen by knuckling our wire. And after we make sure that we are in the true lumen, in the architecture of the vessel with a retrograde injection, as you can see here, we then deliver a special re-entry device called a Stingray balloon, which is basically a flat balloon with two exit ports that are opposite to each other. With angiogram, we make sure that we identify which exit port we need to puncture into with a sharp wire to re-enter the true lumen. And once we do that, we can predilate the lesion and stent and optimize. And so here are her final results. We were able to offer her complete revascularization. So there's many benefits of CTO-PCI, including significant improvement in symptoms such as angina and shortness of breath, as well as reduction in the overall ischemic burden. It enhances LV function, especially in cases of LAD CTO, and it offers the added benefit of achieving complete revascularization. And I'll show evidence for these points in the next few slides. So firstly, there's no CTO that's adequately collateralized. In this study, 59 patients underwent FFR measurements following successful wire crossing of a CTO, and the results showed extremely low FFR values, indicating significant ischemia despite the presence of quote-unquote adequate collateral circulation. So the collateral vessels are insufficient to fully compensate for the lack of antegrade flow. In another study, patients with CTO who had evidence of ischemia at the site of the occluded artery on PET scan underwent staged PCI. And after the procedure, they had a follow-up PET scan. The results showed that patients with extensive ischemic burden, especially of 12% or more, experienced lower rate of all-cause mortality and non-fatal MI. In the EuroCTO trial, which is a randomized multi-center prospective study involving nearly 400 patients, the CTO-PCI with a success rate of 86%, researchers found a significant improvement in both anginal frequency and quality of life in patients who underwent CTO-PCI compared to those who only received optimal medical therapy. In the open CTO registry, which included over 1,000 patients from 12 different centers with a CTO-PCI success rate of 86, there was a significant improvement in symptom relief, and patients showed notable improvement in angina frequency, physical limitation, and quality of life as measured by the Seattle Angina Questionnaire. Additionally, their dyspnea improved as assessed by the Rose Dyspnea Score, and there was a reduction in depressive symptoms that were all significant. In a meta-analysis of 12 trials involving patients with a CTO who underwent cardiac MRI to assess LV function parameters before and after successful CTO-PCI with at least 3-month follow-up, researchers found a significant improvement in regional systolic wall thickness and ejection fraction, and the improvement was particularly notable in patients whose ejection fraction was less than 45% prior to the procedure. So having a CTO really creates a double jeopardy situation in patients with acute MI. In a study analyzing 480 patients with an acute MI, researchers compared patients with acute MI complicated with an out-of-hospital arrest to patients with an acute MI that was not complicated with an out-of-hospital arrest, and they identified several risk factors for out-of-hospital arrest, including chronic kidney disease, left main MI, and the presence of a CTO. In another study, this is a retrospective study of over 2,000 patients admitted with STEMI and treated with primary PCI. Researchers divided the cohort into 3 groups: patients with a single vessel disease, patients with multivessel disease without CTO, and patients with multivessel disease with CTO. And they found that patients with multivessel disease with a CTO was a strong and independent predictor of 30-day and 5-year mortality. And this is because in an acute MI, if the donor collateral artery supplying the CTO is the culprit, it results in a very large area of ischemia. In another study, researchers analyzed 4-year MACE and clinical outcomes stratified by the presence of incomplete revascularization compared to complete revascularization in patients with total occlusions, and they found that a significant increase in MACE among patients who did not undergo complete revascularization, whether treated with PCI or CABG. In contrast, patients who achieved complete revascularization had significantly better outcomes. One of the advances in pre-procedural planning for CTO-PCI is the use of CCTA. CCTAs are particularly useful when dealing with ambiguous proximal caps or when the course of the vessel is uncertain. And this is something Dr. Nick Shakaladze has become very facile at. In this example, the patient had an ostial RCA CTO and a long occlusion. So with good retrograde filling from the LAD septals. There's also a separate occlusion of, let me go back 1 second. There's also a separate occlusion of that PLV branch with also an ambiguous cap. Yeah, sorry, yeah. So using CCTA, we were able to precisely identify the proximal and distal caps of the RCA, as well as the proximal and distal caps of that PLV branch. And with this information, we were able to wire retrogradely into the PDA and RCA all the way up to the aorta. And after pre-dilating the RCA and stenting it, we were able to wire into the PLV branch now that we knew where the cap was. With information obtained from the CCTA, and we were able to restore antegrade flow to a very large dominant RCA. So I'll turn it now to Dr. Sandesara to talk about some of the new devices and ongoing research.
Thanks, Mariem. So we're really at the forefront of innovation and research with regards to CTO PCI. This is an example of a novel device and catheter that was designed from the idea to first-in-man human trial by Dr. Bill Nicholson. It's a re-entry device, microcatheter for chronic total occlusions, with that allows us to perform these procedures with likely increased success rates with antegrade dissection and re-entry techniques, potentially minimize the need for retrograde approach, which most likely will lead to potentially safer and more successful CTO PCI procedures. Additionally, I want to highlight some research done by one of our superstar fellows, Daniel Gold, who spent 2 years doing research with us. He looked at patients from the Emory Cardiovascular Biobank, around 4,000 patients. About 500 of them had a chronic total occlusion. And these are stable patients that present to the cath lab for an angiogram. And we found that patients with elevated levels of high sensitivity troponin levels, as well as BNP levels, had an increased all-cause and cardiovascular mortality. This is in our Emory population. And we also found that potentially those patients with high sensitivity troponin levels that were elevated underwent CTO PCI had better outcomes from a mortality and prognosis standpoint compared to those that did not have elevated troponin levels. Similar story with NT-proBNP levels, where patients with higher median NT-proBNP levels had adverse outcomes and increased all-cause and cardiovascular mortality compared to those without with median NT-proBNP levels less than the median. So these are potential areas of future research, and we're currently undergoing a prospective look at evaluating these biomarkers for patients pre and post CTO PCI and assess their utility in identifying patients that may benefit from CTO intervention. This slide highlights the procedural outcomes of CTO PCI. These are basically 5 or 6 of the largest registries and randomized controlled trial data. You can see the procedural success rates have improved to close to 90% with very low rates of mortality. And from an Emory standpoint, you can see our procedural success rates here at Emory for CTO PCI are in the 90% range, which is higher than the national procedural success rates around the country, with a significantly lower rate of in-hospital MACE and adverse outcomes from a procedure standpoint. So very high volume center with very good success rates, as well as low in-hospital MACE rates. So I'll turn it over to Mariem to kind of summarize.
So CTO PCI offers symptom relief, whether that's angina, dyspnea, fatigue, improved quality of life, and reduced ischemia. That's our primary indication to pursue the CTO PCI. It also possibly improves left ventricular function, especially if it's an LAD CTO. It offers complete revascularization and might improve survival. However, there's a lack in the trial data. In the guidelines, it's a class 2A recommendation by the European Guidelines for Revascularization and a class 2B recommendation in the ACC/AHA guidelines for revascularization. Turn it over to Maddie.
Thank you. So I'm going to talk about CTO PCI for graft failure post-CABG. Start off with a case, 64-year-old woman with an NSTEMI, newly reduced EF. Prior CABG in 2004, has a Lima to her LAD, vein graft to her OM, and vein graft to her RCA. She had a PCI to her vein graft already in 2016, also has the usual comorbidities. Medications listed here. Troponin peaked at 2100, BNP was 54, normal renal function, and her EKG showed lateral ST depression. So this is her diagnostic angiogram. She had a patent Lima to LAD. She has a known mid-LAD CTO, a proximal circ CTO, and a small RCA. We found that she has 95% ISR of the proximal SVG to OM graft that's shown here. So that was the culprit lesion for her presentation. So initially when she came in, we did fix the vein graft, given that that was the acute problem. On IVUS, it showed that there was severe calcific neoatherosclerosis. Did a successful IVUS-guided PCI with a stent in the proximal part, needed to be modified a lot. We used shockwave, laser atherectomy, and cutting balloon atherectomy to try to optimize it. So the question is what to do with failing vein grafts. So when we have a CTO that's bypassed, the patency for non-LAD collateralized CTOs at 1 year are very low. So you can see here it's about 22% for any other branch and 24% for the RCA. When the LAD is bypassed, the percent graft patency is around 100%. And when we look at stent failure versus graft failure at 5 years, so the Lima has obviously a very low rate of failure. Rima is slightly higher, but also less than 5%. And that becomes comparable to the 3rd generation drug-eluting stents. When we compare vein grafts, they're comparable to bare metal stents at 5 years, where the rate of failure is about 30%. So vein grafts are the most commonly employed type of conduit in addition to the Lima. As the vein grafts age over the course of 5 to 10 years, there is a higher risk of failure. And as they get more and more diseased, native vessel PCI becomes preferred over SVG PCI. So for acute occlusions in an NSTEMI or a STEMI situation, SVG PCI can be preferred to treat the culprit lesion if the native vessel PCI is more challenging. But a lot of the time, we'll then come back and fix the native vessel when the patient's more stable to offer them a better chance of having this stay open. This is looking again at the long-term patency of saphenous vein and Lima grafts after CABG. So the patency of SVGs was about 61% at 10 years versus 85% for IMAs. And when SVGs were used for the LAD, the patency rate was still higher than for the RCA or CIRC, but it was on the lower side compared to the IMA. So I'll just show the rest of the case here. So we wired retrograde from the graft. You can see the wire going up here. It's going to get pushed up to the mid circumflex, and then with an injection from the graft and from the antegrade guide here in the left main, you can see the segment of occlusion, which is about 20 millimeters. And so, so we connect the wires here. You can see that this wire here is getting knuckled up into the proximal circ. And then this wire is being wired into the guide liner that we have in the proximal circ so that we can externalize it and convert to an antegrade approach. So this is our final result here. So we were able to open both branches. The vein graft does still have some competitive flow, obviously, because it was open. So we did coil it. There is flow here, but after some time, the coils will lead to graft thrombosis and we'll have a patent native system. I'm going to move on to left main PCI. So this is a case that a 72-year-old presenting with an NSTEMI, severely reduced EF. He's had known distal left main disease that was medically managed for 2 years, ischemic cardiomyopathy with an EF previously 20-25%, prior right MCA stroke, hypertension, hyperlipidemia, troponin up to 3,300, BNP 2,500, and GFR 41. A very abnormal PET, anterior inferior wall ischemia, 70 or 67% of the myocardium, 50% of which was viable, and his EF was very low, as you can see here. So EF around 20%, no LV thrombus, mild MR. This was his right heart cath. Cardiac index is 1.62, so he needed optimization. This was his diagnostic angiogram that shows severe distal left main trifurcation disease and a mid-LED CTO. So I'll go through some data for left main PCI versus CABG. This is a slide showing a meta-analysis of 4 contemporary trials, the Excel trial, Noble, pre-combat, and Syntax. And at 5 years, there's no significant difference in mortality between PCI and CABG. There was 2 trials that went up to 10 years, so the Syntax and pre-combat trials. And again, at 10 years, there's no difference in mortality. Looking at the subgroup analysis of these 4 trials at 5 years, so there's no difference in patients with diabetes, low EF, and even Syntax score less than 22, 23 to 32, and even 33 crosses the confidence interval of 1, but does trend towards CABG being better. This shows, with complexity increasing, CABG does get better when the Syntax score is above 45, which would mean the anatomy is extremely complex. There is a trend towards bypass being better, but when we are in the 10 to 33 range, PCI is still equivalent. So the Syntax 1 trial that was published in 2009 did include 1,800 patients. This was patients with 3-vessel disease or left main that were randomized to CABG versus PCI. The higher MACE rate at 12 months in the PCI group was mostly due to the increased rate of repeat revasc. This trial was done with earlier generation stents. There was no IVUS guidance, and revascularization was not based on functional assessment or ischemia. So the Syntax 2 trial had a more contemporary approach to revascularization. So they used ischemia-driven or FFR, IFR, new generation drug-eluting stents, and IVUS guidance for drug-eluting stent implant. The CTOs were done at treatment centers with CTO expertise for complete revasc. So this is just showing the difference between Syntax 1 and Syntax 2. So with physiology guidance, there was a lower number of lesions that were treated per patient in Syntax 2, higher success rate for CTO, PCI, and Syntax 2, and a much higher use of IVUS. So this is looking at the Syntax 1 versus 2 3-year results. So this is all-cause mortality. There's a 33% reduction, MI 67% reduction, and lower rate of stroke, although that was not statistically significant, and then a lower rate of any repeat revasc, and this is both PCI cohorts. And then comparing the Syntax 1 CABG patients versus Syntax 2 PCI, these are more equivalent, so there's no difference in all-cause mortality, stroke, MI, or any revascularization when looking at these 2 cohorts of patients.
In diabetes too.
What's that?
In diabetic.
Oh, and diabetics as well. So for going back to this case, he was reviewed with the heart team. His risk of CABG was prohibitive, so we planned for multi-vessel PCI with Impella support. His right heart cath prior to intervention showed improvement in his hemodynamics. And so we did a successful mid-LED CTO PCI, and then did a bifurcation stent to the left main LED, and then left main into the ramus, and we ballooned the circumflex open. So he was discharged home on good medical therapy, was doing well at follow-up, had a CRTD upgrade done as an outpatient, and his follow-up echo showed improvement in his LV function. So to summarize, left main and multivessel disease, there is equipoise between PCI and CABG for treatment of left main disease with state-of-the-art contemporary PCI tools and techniques, including IVUS and physiology guidance. There's no difference in subgroups, including diabetes, low ejection fraction, or syntax scores of less than 33. For treatment of multivessel disease, there's also equipoise between PCI and CABG using the same tools and techniques we talked about. And of course, a patient-centered approach and heart team discussion is important for these cases. Pass it back to Mariem.
Okay, so let's shift gears here and we'll talk about in-stent restenosis therapies, starting with a case. This is a 84-year-old male who presented with class 3 angina in the setting of multi-layer ISR of his RCA. He had multiple comorbidities and he is on optimal medical therapy. Here are his angiograms showing multi-layer RCA ISR with severe calcification. The RPDA is a CTO supplied by left to right collaterals. So we use an algorithmic approach to treat ISR that starts with intravascular imaging to determine the underlying pathophysiology. The potential mechanism behind in-stent restenosis includes either neoatherosclerosis, neointimal hyperplasia, or stent fracture, or stent underexpansion. And once the mechanism is identified, the treatment strategy is tailored accordingly. There's also an antiproliferative treatment algorithm which we employ, which varies based on whether there's ISR involves a single stent layer or 2 or more stent layers. If there's only 1 stent layer, then we can consider adding another stent. But if the ISR involves the left main or bifurcation, or there's a risk of jailing a large side branch, or if it's a vein graft, all of which do not favor placing another stent, then best management would be to do brachytherapy or drug-coated balloons. If there are 2 or more layers of stent, then deploying yet another stent is really ill-advised. And here we would either do brachytherapy or use drug-coated balloons. So going back to our case, what we did was we wired into that RPDA with a Mongo wire, which is a polymer jacketed wire that's special to navigate complex lesions. We were able to pre-dilate the ostium of the RPDA with a low profile balloon. We then IVUS to make sure that we understand the pathophysiology behind the neoatherosclerosis, which here it was severe calcific neoatherosclerosis. We then used atherectomy, rotational atherectomy with a 175 and a 1.5 burr, which is basically a diamond tip burr that is mounted on a catheter, and the burr is advanced to the lesion. Sorry, let these play. And it rotates at a very high speed, gently grinding the calcified plaque into microscopic particles that are then absorbed by the bloodstream. We then performed brachytherapy from the proximal RCA to the PDA, and here are our final results. Okay. So in a large prospective study of more than 500,000 patients comparing clinical outcomes between patients who underwent ISR PCI versus de novo lesions, the researchers found that ISR group had a significantly higher rates of MACE, death, myocardial infarction, and target revascularization compared to patients with de novo lesions. And that's why finding better ways to treat ISR is important. And here at Emory, Dr. Pratik Sandesara has initiated the brachytherapy program. And it's so the intravascular brachytherapy, what it does is that it impedes new intimal cell growth at target arterial segments without causing damage to the healthy surrounding tissue. And the radiation exerts positive effect on restenosis and has an anti-inflammatory activity such as decreasing chemotaxis and inhibition of leukocyte migration, cytokine production, and macrophage activity. There's a newer technology that has recently been FDA approved here in the United States is the use of drug-coated balloons. The balloons deliver paclitaxel, which is an antiproliferative drug, helping to prevent restenosis by inhibiting smooth muscle cell proliferation. So in the Asian trial, they randomized patients with in-stent restenosis lesions to either drug-coated balloon versus uncoated balloon angioplasty. And the results of this trial indicated that the Asian drug-coated balloons is superior to conventional balloon angioplasty in reducing target lesion failure for the treatment of ISR at 12 months. Lastly, we want to mention quickly emerging therapies for patients with refractory angina. The coronary sinus reducer system. It's a medical device that's designed to treat patients with refractory angina who are not candidates for coronary artery bypass grafting or PCI. The system involves a small stent-like device that's implanted in the coronary sinus to reduce the flow of blood, which increases pressure in the veins and enhances coronary perfusion, with a hope that this might improve myocardial oxygen delivery and help alleviate anginal symptoms. So the Coursera trial that they recently published in the New England Journal is a small clinical trial. They enrolled 104 patients with class 4 and 3 angina who had evidence of myocardial ischemia and were not candidate for CABG or PCI. They randomized them to implantation of the coronary sinus reducer system or to a sham procedure. And their primary endpoint was a proportion of patients with an improvement of at least 2 angina classes at 6 months. And the study showed that implantation of the coronary sinus reducer device was associated with a significant improvement in symptoms and quality of life in patients with refractory angina. And they also did CT angiograms in 36 of the 50 patients who received the implant with no evidence of device migration or occlusion. So Dr. Brian Kindy implanted our first coronary sinus reducer system here at Emory a few weeks ago. The patient was a 71-year-old female with multiple comorbidities and a class 3 angina on 4 anti-anginal medications. She had a very large, severe intensity reversible perfusion defect on her PET scan that you can see here, involving 65% of the LV with a TID ratio of 1.27. And I'll go over her angiograms very quickly. She has patent stents in the RCA with mild ISR. And the graft to her OM is patent. There's also the graft, her lima to LAD is also patent, but there's a CTO of the distal LAD, which is the culprit and a source behind her angina. So this is the graft to her OM that's patent. Her left main is severely diseased. Proximal LAD is a CTO, and the proximal circ is also a CTO. To deploy the device, the procedure really takes about 15 minutes. We gain internal jugular venous access, we wire into the coronary sinus and deploy the device, and the patient can be discharged the same day. In conclusion, so symptom relief, improved quality of life, and reduced ischemia are all primary indications for CTO-PCI. State-of-the-art tools and techniques, including new generation drug-eluting stents, intracoronary imaging, and physiology-guided PCI have led to improved clinical outcomes following complex PCI. And there's equipoise between PCI and CABG for left main and multivessel disease in contemporary trials. Drug-coated balloons and intracoronary brachytherapy are important tools for the management of in-stent restenosis. And lastly, coronary sinus reducer therapy is an emerging option for patients with refractory angina. Thank you. It's like, anyone has any questions?
Thanks, thanks, Mariem, Maddie, and Pratik. We'll take any questions anybody has. You know, the program here is comprehensive. It's a very busy program. We're doing over 400 CTO PCIs per year at this point, which would make us the top or the top 2 busiest centers in the United States, and you know, involved in a lot of these clinical trials. Usually the lead enroller most of these trials, and we have a number of people here that are national PIs on the trials too. So it's with what Pratik's done with the brachytherapy program has made it really a comprehensive kind of destination center for complex disease. And our MCS use is not exceedingly high just because we don't feel like we need it for a lot of cases, but we certainly have an active mechanical support program when necessary, and you're doing over, I would guess, 120 to 130 unprotected left mains per year. So there's really nothing that's not approachable. Like I said before, we still have a hard team approach, and there's still times when surgery is a better option, but we certainly have a pretty comprehensive arsenal to offer. So any questions that people have are welcome to ask, and hopefully we can answer.
Bill, this is Spencer. I congratulate your team on really becoming the leader in this CTO business. As you know, it's there are all kind of opinions about it, and I think the evidence you're accumulating that confirms that you're really making patients better with the CTO is very important, and the technology you're applying is super. So congratulations for leading the way in education for CTO interventions. You'll continue to fight a battle with people that say, well, does it really matter? And you just got to keep proving that. I would Pratik, point out that I'm excited that you've restarted the brachytherapy program. I would just say that you've restarted the brachytherapy program. Of course, everybody knows that the brachytherapy program actually originated here at Emory. And so I'll just make that little side comment.
Yeah, that's fantastic. Thanks for the nice comments. Yeah, certainly brachy was invented here years ago. And then I remember when I was a fellow, like when drug-eluting stents came out in 2004, I think 1 out of every 3 cases was a brachy case. And then all of a sudden, drug-eluting stents just ended it. But it's back now. And, an in-stent restenosis is a real problem. Just so people have it in context, it's probably about 13% of all the PCIs being done in the United States this year are in-stent restenosis. And, there's about 1 million PCIs done in the United States. So that's a lot of cases. And most of that is a result of whoever the first operator was that put the stent in did not do a good job. And, usually those stents are put into a vessel that was not modified from the calcium standpoint, so you didn't get optimal expansion. And so there's times when we still see neointimal hyperplasia or neoatherosclerotic disease inside the stents. But the vast majority of them are not a patient problem. It's a doctor problem when the doctor didn't prep the vessel properly, didn't size the stent properly, and didn't use IVUS-guided imaging, which is standard here. IVUS-guided imaging, if you achieve an MSA medium stent area of 80% of what you're hoping to have it, and you don't have dissections and you have good TIMI3 flow, you'll cut the mortality rate of those patients in half, which is incredible. So, and it's still probably used in less than 15% of the cases in the United States. So,
Bill, I see that Bob Taylor had a question, which everybody asks is, how in the world does a coronary sinus reducer make you better?
Yeah, that's a good question. So I'm not sure we have a really good understanding of what the scientific philosophy behind it. I mean, you're increasing congestion in the venous drainage. The data out of Europe looks pretty impressive as far as people with symptomatic relief. With the trial we're in is really interesting. It's a sham trial versus a real device. So I think you're going to truly see, the patient gets on the table, you get their IJ stuck, you go into coronary sinus, shoot a coronary sinus venogram and make sure that there's adequate anatomy, and then the patient gets randomized, and the patient doesn't know if they got the device or didn't get the device. So I think we're going to see if it really works. It's like a lot of things in the past, like EECP and things like that we go back to that nobody really, I think, bought into. But it's an option, right now for when there are no other options. And so, but the anatomy, the physiology is a little bit of an enigma to me as well. So, I'll just say a quick word about the drug-coated balloon program. That's old technology for Europe and Canada. It's been around for 10 years, but in the United States, we finally have it now. And we were, I think, the 3rd or 4th enroller in the agent trial that got the FDA approval for that. So that technology is here. We've been a little bit slow rolling that out just because it's obscenely expensive. They're charging like $6,000 for the balloon. So, we've been kind of a little bit reserved about using it just for the cost, but there's a pass-through code coming through the 1st of January that will cover a lot of the costs of that. So that it's going to be a much more common offering for patients, and really an interesting technology. I mean, you see almost no thrombosis with it. So there's going to be some interesting applications are going to go back to, like you said, Spencer, the days of brachy. We're going to go back to the days of plain old balloon angioplasty again. And so I think it's going to be, like you wrote an editorial, it's a back to the future kind of thing. So, any other questions?
Hey, Bill, Steve Clements.
Hey, how you doing?
So I was glad to see Spencer on the line, but I just want to say congratulations to you and all that you've done. Too bad Andreas is not around to see this. The progress that we've made from 1977 going forward to this point is absolutely amazing. And congratulations to you for taking it to the next step.
Well, thanks.
I know your dad would be proud. I know he is proud.
Appreciate it. Thank you.
Hey, Bill, it's Bob Taylor with a question from the non-invasive cardiologist. So in addition to why does that stent in the vein in the coronary sinus work, which is bizarre, but the real question is, so given that, you know, how wonderful all this technology is, why are the higher syntax score patients really doing better with CABG? Do you think there's some site dependence on that? Do you think in a truly world-class expert site like this that they really do better?
It's a good question. I mean, I think, you know, obviously we're a little bit biased. I think IVUS guided imaging is a huge deal. Like, I think we've talked about it so much at our conferences that it's been beaten into everybody that it's almost not acceptable to not do it. When the complexity gets up high, you know, I'll go back to what I always say, like, you know, there's a lot of heterogeneity in surgery and there's a lot of heterogeneity in PCI, like you're alluding to. And I think if you have high quality, complete revascularization, optimized stents, and good medical therapy afterwards, I think we're competitive, and the data for Syntax 2 would sort of support that regardless of the Syntax scores that you get to, we're competitive, and I think it's more reflective of the degree of complete revascularization that you achieve, maybe what your residual Syntax scores. If we can get that below 8, you know, we're very, very competitive with surgery at that point. You know, I think we are very competitive, but I think there are times we still do not do well with the ostial circumflex. We don't do well with the ostial right, areas that have recoil and heavy calcification, and we're very cognizant of that. So, like, you know, when we have those cases, we're much more apt to consider, you know, preferred surgery in those patients, just because you end up with a recurrent restenotic issue. So, I mean, I think there's a lot of complexity that goes into it, but, you know, anyone that looks at an angiogram and says this isn't revascularizable interventionally should not give that opinion, because everything is revascularizable interventionally, you know. So I think our job is to optimize and get the best. The first procedure is the most important one. It has to be done correctly. If you set them up for failure with an underexpanded stent or an undertreated coronary ahead of time that's not optimized, then you put them on a destination for recurrent events. Well,
Thank you.
appreciate everybody.
I love that quote that there's nothing that we can't revascularize.
There really isn't, you know, and I think, like, it's you know, it's always like, I always wonder when people look at a film and say that this can't be fixed. That'd be like me recommending a chemotherapy. I think you should probably ask the team that does this all the time. So, I mean, I think it's a incredible, like Dr. Clements was saying. I mean, what's changed over at least in my career for the 22 years of doing this, it's pretty remarkable what we can do nowadays. There's not much left. Well, that's great. Thanks for inviting us to show some of what we're doing, and hope everybody has a great day.
The preceding program is copyrighted by Emory University.